Welcome to this room and welcome to the 2021 Water Conference. My name is Lunit Silne and I will be the moderator for this session today. Just before we get started, there's a couple of few announcements that we're going through and then we'll get right on with it. So I welcome all the participants. As you may already know through other rooms that you've been to, there are a couple of networking and sponsor sessions that you are able to attend throughout each day of the conference. You can easily hop in and out whenever you need to. The afternoon sessions will be from 3:30 to 5 Eastern time daily. You can follow easily remotely. We also have the late early show. So if you did not catch the very, very early show yesterday, you can still catch the one today. You can join us tomorrow, morning, afternoon, and evening for a quick recap of today's event. And we'll have Dr. Regina Sauter and Dr. Alexander will discuss the lessons learned from the day and how to apply them to Southeast Asia and the Pacific region. And we also have another session that I would highly recommend that you attend is the Careers in WASH for Young Professionals, where people from different organizations and different journey in the WASH sector will present information regarding their organizations and possible ways to get engaged. And this is there are the other rooms where you can also go to and attend other sessions. So today this is room 4. So there is room 1 to 3 that are also hosting different sessions and different topics. And we thank all our sponsors, RCI, SATO, and also UNC for hosting the water conference. So today we'll have our verbal presentation. We'll have a total of 3 presenters. Our first presenter will be Erica Vermeister. She'll be looking at the global analysis of community sanitation coverage and antibiotic resistance in the human gut. And we'll have Dr. Christine George, who will go over child mouthing of soil and contaminated Fomites and improved sanitations and the developmental world. And we also have a research associate, Dennis Volter, who will be looking at FSM service delivery. So so these were our announcements. We'll go more into some more things to be mindful of prior to the presentation. So now for a couple of technical instruction, this session is being recorded for folks who could not attend the live session. Everyone will be muted but the presenter at the time. And please, all questions that you may have need to be directed into the chat tab and Pathable. The Zoom chat is disabled, so you won't be able to submit questions there for us to see or for the presenter to notice. So you'll have to submit all of them via Pathable. And all the presenters will also have their slides up, so you'll be able to follow along. If anyone have any other questions, feel free to ask into the Pathable tab for any technical issues that you may have. So our first presenter for today is Erica Vermeister. She's with Tufts University, and she'll go ahead and introduce us to her topic. Dr. Erica, you can go ahead and share your slide.
Thank you. Let me just get this situated. Okay. Hi, everyone. Thanks so much for having me here today. I'm excited to tell you about our project on a global analysis of community WASH coverage and antibiotic resistance in the human gut. And I want to thank and acknowledge all the co-authors that have been involved in this work. So through this project, we were interested in the intersection of 2 related fields, and that's WASH and antimicrobial resistance, or AMR for short. And the reason that we care about antimicrobial resistance is that by 2050, there's predicted to be 10 million deaths per year due to AMR. And this is largely driven by antibiotic usage in both humans and animals. So here we have the change in the consumption of antibiotics in humans over the period of 2000 to 2015. And we can see in red where consumption increased over that time period, and it's many low and middle income settings. And then in blue, we can see where consumption decreased, which is in some high income settings. And so right now, when we think about how we combat antimicrobial resistance, one of the primary solutions that's proposed is stewardship, which through education, reducing the prescription of antibiotics. But what can we do in settings where there's a lot of unregulated antibiotic usage, as well as a relatively high burden of infectious diseases? And so we are proposing to look at not just stewardship, but also WASH. So how can effective WASH reduce antimicrobial resistance? Well, first, effective WASH can interrupt transmission of antimicrobial resistant microorganisms, both pathogenic and non-pathogenic and resistance genes, by blocking transmission between humans, animals, and environmental reservoirs. Second, effective WASH can reduce the infectious disease burden and therefore associated use of antimicrobials, which reduces selective pressure for the emergence of resistance in the gut. And third, effective WASH could prevent the release of antimicrobials into the environment, which would reduce the potential selective pressure for the emergence of resistance in the environment. So the goal of this work was to leverage publicly available human gut metagenomes to first characterize global variation in the resistome, which is defined as the composition of antibiotic resistance genes in a microbial community. And second, to determine the association between abundance of resistance genes and access to improved drinking water and sanitation. And so the way that we did this is we did a search of human gut metagenomes in NCBI sequence read archives. So in theory, whenever a study is published that generates sequencing data, it should be deposited in a public repository. So from this search, we kept all human gut metagenomes from low and middle income settings and a subset of metagenomes from high income settings. And along with the sequencing data, there's also metadata available in the SRA, and that includes GPS coordinates as to where these metagenomes are from. So using these two pieces of information, we calculated total abundance of antibiotic resistance genes normalized to the total abundance of bacteria in these metagenomes. And then using the GPS coordinates and household level surveys like DHS and MICS, we calculated access to improved drinking water and sanitation in a 25-kilometer radius of the GPS coordinate. So we identified a total of 36 studies that met our inclusion criteria, and this was about 1,600 metagenomes from 27 countries, which are shown here in the map. And so the color refers to the urbanicity, and then the size of the dot references how many metagenomes there were from that GPS coordinate. Okay, so towards our first objective, characterizing the resistome, we're interested in the total abundance of resistance genes in each WHO region. So on the x-axis, we have our region. The y-axis, we have ARG abundance, which is a log normalized quantity. And we can see that while the abundance is relatively similar throughout the world, the highest abundance was in Africa. And then I didn't show you this, but when we separate the data by rural and urban in each of the regions, there's no difference between rural and urban, except for in Southeast Asia, where there is a higher abundance in urban areas. Okay, again, so still characterizing this resistome. I know this is a little overwhelming, but I'm going to take you through one panel of this plot before I show you the rest. So on the x-axis, each individual line represents one sample or metagenome. And then the square is all of the samples from that study. And for Cameroon, for example, there are 2 studies from that country. On the y-axis is relative abundance. So this is the percentage of the resistance genes that are part of different drug classes, and the drug classes are shown in the different colors, and white refers to other drug classes that are not listed here. And it's grouped by WHO region again. And so here we're looking at Africa, and we can see that the blue, which is tetracycline, is very abundant. And this is not just in Africa, this is everywhere. And outside of our blue color, there's a lot of gray, which is beta-lactams. So in Southeast Asia, again, this is average relative abundance other than tetracycline. The highest was beta-lactams in gray, and then pink, which is MLS, macrolide, lincosamide, streptogramin. And then in Europe, on average, the second highest was beta-lactams. In Western Pacific, again, we can see a lot of this pink, which is MLS. And then in the Americas, there was a high degree of variation between different study locations. And you see, for example, in Ecuador, other than tetracycline, there was a fair amount of beta-lactam resistance. Okay, so on to our second objective, where we're interested in the association between ARG abundance and the coverage of water and sanitation. So again, this is within a 25-kilometer radius of our metagenomes. We calculated the fraction of households that have access to improved water and sanitation. And we did this using generalized linear models. So on our x-axis is our coefficient in the model. Here I'm calling it our estimate. And then our adjusted model is shown in gray, and this is the estimate and the 95% confidence intervals. And we did this for 3 different scenarios. So the first is we looked at association between abundance of resistance genes and access to both improved drinking water and sanitation. Our second scenario is abundance of resistance genes and access to sanitation only. And third is access to improved drinking water only. And what did we find? Well, we can see that with increased access to improved drinking water and sanitation, there was a decrease, our estimate is negative, in ARG abundance. When we compare sanitation versus water, we see a greater reduction in ARG abundance associated with sanitation in comparison to improved drinking water. But the strongest effect, again, was shown with access to both improved drinking water and sanitation. So next we looked at associations by different subgroups. So in orange, we have by income classification, in green, by antibiotic consumption in animals, in red, by antibiotic consumption in humans, and then in bluish purple, it's by WHO region. And here we can see, again, the strongest effect is in lower income countries, and then countries with lower consumption of antibiotics in both animals in the green, and then humans in red. And then when we look at the different WHO regions, we see the strongest effect in Southeast Asia. And all of these estimates are negative, except for Western Pacific, where our estimate is positive, meaning with increased access to improved sanitation, there was an increase in ARG abundance. And this is likely due to the fact that in the countries that we found data from in the Western Pacific, many were high income settings.
2 more minutes.
So our main findings are that with increased access to improved drinking water and sanitation, there was a decrease in overall ARG abundance in human guts. We saw a greater reduction in ARG abundance associated with sanitation in comparison to drinking water, but the greatest effect was access to both improved drinking water and sanitation. And there was the stronger association in low-income countries and countries with lower usage of antibiotics in both humans and animals. And so why does this matter? Well, I mentioned stewardship right now is one of the main strategies that's used to curb antimicrobial resistance. And the WHO Global Action Plan on AMR, they mention WASH, but particularly in healthcare settings. And then in a study that was done where they looked at all the 77 national action plans that are in the WHO library, only 11 of them specifically mention WASH in community level, so non-healthcare settings. And so with the results of this study, we're proposing that we not just focus on stewardship, but also use community level water, sanitation, and hygiene as a strategy to combat antimicrobial resistance. And I just want to acknowledge again, all of our co-authors and funding agencies. And with that, I'll take questions. So I guess I'll go back to here.
Thank you so much, Erica. Please put any questions that you have in the Pathable chat tab, and I'm currently monitoring it. Feel free and put in your questions. So I do have one question, Erica. What type of criteria did you use when selecting the different countries?
Yeah, that's a good question. So first of all, there's not that many studies that have this metagenomic data rather than 16S is like more common amplicon sequencing. So that alone was pretty selective. And then we had to be able to identify a location. So those two criteria were the most important and also pretty selective in terms of what we could include. And then for higher income countries, we were looking for good geographic distribution. So, not just choosing studies from Europe and the US, but getting distribution from around the world.
Thank you. Someone just posted something in the chat. So Gemma Phillips said that they are interested in the binary way that sanitation was determined as with or without. And they wonder if the results will be even more striking if it was possible to select the location with safely managed sanitation. Do you think that was a limitation?
Yeah, so the way we calculated sanitation was by taking all of the households that were in a 25-kilometer radius in DHS surveys, for example, and then of those households, calculating the fraction that had access to improved sanitation. And when we started this project, we're interested in safely managed, but there just wasn't enough data in terms of treatment, for example. So we're definitely interested in that, but right now it's a limitation in terms of the data that's available.
Drew Capone has another question. So salutation to you, Erica. And so he's asking, what were the units or of estimates on the x-axis of your figure showing the reduction with sanitation and water?
Okay, so the estimate it's our coefficient in our linear model. So it corresponds to a 1 unit increase, or in terms of the fraction for sanitation, because we did it as a percentage, it refers to a 100% increase in access to improved drinking water and sanitation would be associated with whatever that value was in the estimate.
Thank you so much for all the questions. So we do have 2 more minutes left for any additional questions that may need answered. Another question I had was, since you mentioned stewardships and education as part of one way to address the issue of antimicrobial resistance, did you find any literature pieces involving water sanitation and also policy work, not simply the research side of things?
I think in terms of the policy, we were interested in these action plans. So I guess what I had on the next slide, because I think that's really where a lot of countries are stating their policies and what they're going to be doing to combat antimicrobial resistance. And again, I think they just tend to focus on stewardship and also healthcare settings. So to me, it was pretty striking that only 11 out of the 77 include mention of community level wash. And even that, it's just mention of it. It's not necessarily like detailed plans. So yeah, I think focusing on these national action plans is important in terms of what's happening with AMR policy.
Thank you. So we have 1 more minute for any more questions. I do have 1 more question. Did you look at differences between rural and urban settings in terms of detection?
That's a really good question. And basically we ended up with what was out there. And so we identified, for example, in Africa, a lot of the studies were in rural settings. And then one interesting thing that we identified as a pretty big gap in the literature is that we couldn't find any rural studies that were explicitly from high income settings. So ideally, we'd want this good balance between rural and urban, but we ended up with basically the biases that are associated with what studies are already out there. And so, like I mentioned, you end up with a lot of rural studies in Africa, and then in high income settings, mostly urban.
Well, thank you so very much for your presentation and for showing us what you've learned in your research. Our next presenter is Dr. Christine George. She is with the Johns Hopkins University, and yes, there you go. She's already on top of it. She already started sharing her slide, and she'll be introducing us to her topic. Yeah.
Thank you for the introduction. So my name is Christine Marie George, and I'm an associate professor at Johns Hopkins. And it's my pleasure to present on today our prospective cohort study on risk factors for poor child developmental outcomes in urban Dhaka, Bangladesh. And this study was a collaboration between my research group at Hopkins and the International Center for Diarrheal Disease Research Bangladesh, ICDDRB, and this work was funded by USAID. And the rationale behind our work is that each year, millions of children in low and middle income countries are not meeting their developmental potential. Chronic enteric infections have been associated with malnutrition and poor cognitive outcomes. Furthermore, malnutrition is associated with impaired immune function, which makes children more susceptible to enteric infections. And this leads to the vicious cycle, which I show here, where chronic enteric infections lead to malnutrition, and malnourished children have worsening nutritional status, resulting in growth faltering and poor cognitive outcomes. However, despite this evidence, there's very limited studies on WASH-related risk factors for child cognitive developmental outcomes. Most studies are focusing on risk factors for diarrheal disease and impaired growth. And so our objective in conducting this study was to build an evidence base in this area. And so this prospective cohort study is part of the larger CHOBI-7 research program, which is focused on designing theory-informed, evidence-based WASH interventions to reduce exposure to fecal pathogens, with the goal being to improve gut health and the ultimate goal being to improve child health. And for the CHOBI-7 program, our intervention development relies on 3 key pillars. The first being to conduct prospective cohort studies to identify risk factors for child morbidity so that these can then be targeted as part of interventions. Our qualitative work focuses on identifying psychosocial, contextual, and technological factors that are driving our WASH behaviors. And then we conduct pilot studies to identify the feasibility and the acceptability of the interventions, as well as to obtain feedback from beneficiaries so that refinements can be made to the interventions. And as part of the CHOBI-7 program, once the intervention is developed, we conduct randomized control trials to look at the efficacy of the approach in terms of improving child health. And to date, we've conducted 3 randomized control trials as part of the CHOBI-7 research program. And so for today's presentation, I'm going to focus on our cohort study. And so my research group at Hopkins is very interested in novel transmission pathways for fecal pathogens, and in particular fomites. So fomites being inanimate surfaces and objects that are capable of transmitting microorganisms. And this includes soil, it can include a ball a child is playing with, or bottles and sticks. And anyone that has young children knows that children are constantly putting things they come into contact with in their mouth. And this is how they're learning about their environment. However, in settings with high fecal contamination, this can pose an exposure route to fecal pathogens. In our previous work that was conducted in rural Bangladesh, as well as in the Democratic Republic of the Congo, has shown that child mouthing behavior is associated with diarrheal diseases, environmental enteropathy, and impaired growth. And so we sought to build this evidence base further by investigating the association between child mouthing behavior and child cognitive developmental outcomes. And so our study was conducted in urban Dhaka, Bangladesh, in some areas in the capital city. And we conducted a 12-month prospective cohort study where we followed 224 children that were under 5 years of age. During this period, we conducted monthly surveillance where we obtained information on caregiver-reported hygiene practices. And this included caregiver reports on child mouthing of soil and visibly dirty objects, as well as child feces disposal practices. We conducted spot checks to obtain information on wash infrastructure, such as latrine type, as well as the presence of animals and child sleeping spaces. And then at our 12-month follow-up, we conducted a child cognitive developmental assessment. And this was done using the Extended Ages and Stages tool, which is an adapted version of the Ages and Stages questionnaire for children in low and middle income countries. And the Extended Ages and Stages tool, which is referred to as the ESAQ, was recently used in the WASH benefit study conducted in Bangladesh. And this study combines 5 cognitive domains as a measure of child developmental outcome. And so this includes communication, fine and gross motor, and personal, social, and problem-solving abilities. And these are combined to comprise the ESAQ combined Z-score. And so now I'll go into our child mouthing results. And so we observed that 60% of children had mouthing events that were reported by their caregivers. So this is mouthing of visibly dirty objects at the majority of surveillance visits. And we use the majority of the surveillance visits as a measure of frequency of the behavior. When we looked at soil, we observed that 27% of children were observed by caregivers to mouth soil at the majority of visits. And again, this is an urban context. And so this picture on the right helps to put our findings into context. You can see that although it's an urban setting, in some areas, the roads are often made of dirt. And so there's the opportunity for children to come into contact with contaminated soils in their environment. And then going on to our child feces disposal findings, we found that 4% of children lived in households where caregivers reported unsafe child feces disposal at the majority of visits. And safe child feces disposal was defined as putting feces in a latrine. We did not include buried because we were working in an urban context. And then we found that 9% of children lived in a household where they had an animal in their sleeping space. And this was most commonly pigeons, as you can see here on the right. And then finally, we found that 5% of children resided in households with unimproved latrine being present or unimproved sanitation option using the JMP definition. So now I'll go into our regression results. We found that caregiver reported child mouthing of soil and visibly dirty objects at the majority of surveillance visits was associated with significantly lower combined ESAQ Z-scores at our 12-month follow-up. So this means that child mouthing of soil and visibly dirty objects was associated with significantly lower child cognitive developmental outcomes at our 12-month follow-up. In addition, we observed that children that resided in households with unimproved sanitation also had significantly lower combined ESAQ Z-scores at the 12-month follow-up. So in summary, we found that the majority of children were found to be mouthing dirty fomites at surveillance visits. And we observed that children who mouth soil and put visibly dirty objects in their mouth at the majority of surveillance visits had significantly lower combined ESAQ Z-scores. And in addition, we also found that children that lived in households with unimproved sanitation had lower combined ESAQZ scores. And so to summarize these findings further, these findings demonstrate the importance of interventions targeting child mouthing. And as I mentioned earlier, this builds on our previous work in the Democratic Republic of the Congo and in rural Bangladesh, where we found that child mouthing of soil and visibly dirty fomites was associated with diarrheal disease, environmental enteropathy, and impaired growth. And in addition, we found in this study that sanitation infrastructure was associated with lower cognitive developmental outcomes, poor sanitation infrastructure. And so these findings indicate the need for improved sanitation options in our study setting in urban Dhaka, Bangladesh. And so to end my presentation today, I wanted to go back to our work as part of the CHOBI-7 program to develop interventions to reduce childhood exposure to fecal pathogens. And so we developed a communication module based on the findings from our cohort studies to try to reduce this child mouthing of soil and visibly dirty fomites among our target population. And so this was done through qualitative research, which included in-depth interviews, focus group discussions, and a pilot study of 102 households. And so this led to the development of 7 Baby Wash mobile health program. And this module that I'll focus on today was the child mouthing module. And this intervention is initially delivered through home visits and then reinforced through voice and text messages that are sent weekly for 3 months. And so this intervention targets 3 key behaviors. The first behavior is caregivers stopping children from putting visibly dirty fomites into their mouth. This includes soil and visibly dirty objects, as well as having children sit on a mat, both when they're playing, as well as when they're eating food. And the eating food one came through our formative work, which showed that children were often sitting on the ground when they were eating, and that the food that they were eating was falling onto the ground and they were putting it back in their mouths. So to try to reduce this exposure to potentially contaminated soils in the environment, we included this key behavior. And in addition, we encourage caregivers to frequently wash with soap or detergent powder the toys or objects children frequently put in their mouth during the day. And in our study, the most common object that children were putting in their mouth was actually balls, and this was followed by bottles. And so really encouraging caregivers to clean these items frequently to try to reduce fecal contamination from being present. And so in our pilot study of 102 households, we found that this intervention was feasible to deliver, including the mobile health component. And we saw that the intervention was well received by beneficiaries. And so we're very interested in taking the next step forward with this work to conduct a randomized control trial to see if this child mouthing intervention could help to reduce diarrheal disease, growth, and child developmental outcomes among our target population. And so that concludes my presentation today. And I would like to acknowledge our large CHOBI-7 study team, which spans across ICD-DRB, the Bangladesh Ministry of Health and Family Welfare, as well as Johns Hopkins, for all of their many contributions to the implementation of this work that I present today. And so here I show a photo of our team in Dhaka. And with that, I conclude the presentation, and I'm happy to address any of your questions. Thank you.
Well, thank you so much, Christine, for our presentation. This was a very great presentation. As usual, we have the Pathable Chat available. If anyone has any questions for this presentation for Dr. George, I would be delighted to say them out loud for you. Anyone have any questions? We have 3 minutes for questions.
And I should also mention, while people are typing in their questions, that yesterday I gave a very similar presentation on our work from the Democratic Republic of the Congo. And there we found that soil with detectable E. coli in child play spaces was associated with significantly lower child developmental outcomes. And so this was also a prospective cohort study. And so we're really interested in broadening this literature on what are WASH-related risk factors for child cognitive developmental outcomes.
while we are waiting for some questions to come in the chat, I had one question. So from a class I'm taking, my professor was going over how sometimes children's feces are not regarded as highly toxic, quote unquote toxic, as an adult feces. Did you encounter this situation in your study as well?
Yes. And so actually Fatima Zora, who's a part of the session today, was leading a lot of our formative work related to this. And we found both in urban Bangladesh as well as rural DRC that often people felt that child feces was safe, and that it was particularly infant feces, and that as the child got older, it became unsafe. But for the very young children, that the feces was safe.
Thank you. Okay, we have one question from Yale Mason. How was the effect of other variables such as malnutrition, unsafe drinking water neutralized in the analysis in such a way that only the effect of fomites could be studied?
Thank you for your question. And it's great to see you again at the meeting this year. And so we actually included dietary diversity in our model, and we didn't find that it significantly changed our observed associations. And so we also had information on animal source food, as well as protein consumption, and that didn't affect our observed association. And thank you, that's a very important question.
We have one more question that may be the last one too, from Rick Johnston. Was the presence of animals in the sleeping space correlated with ESQ? We saw that improved sanitation was, but most of the participants already had improved sanitation at baseline.
Yeah, so it was not, which was an interesting finding for us. And so it indicates in this particular setting that this was not a significant risk factor. And it was in the expected direction. And so when we looked at the ESAQ, it was negative 0.23 for the combined ESAQ Z-score associated with the animals being present in the child sleeping space, but it was not significant. But I think this needs to be further explored in other settings as well before we come into any solid conclusions. These findings are only relevant for our study population in urban Dhaka, Bangladesh.
That was our time. Thank you so much.
Thank you,
Dr.
everyone.
George.
And I'll be happy to address any other questions you have by email. Thank you.
Yes, and if you did not know, you can actually reach out to some of the speakers through the water conference site. Maybe use that as a way to also reach out to the presenters. So our third presenter for the day is Dennis Volter. He's a research and development manager with Vidura. Dennis, you can go ahead and share your screen with us. And you have 10 minutes.
Perfect. Good day, good afternoon, good evening, everyone. I hope my screen should be sharing right now. I warmly welcome you to this presentation titled, "What can we learn from call center data in FSM service delivery?" My name is Dennis Volter, and this research was conducted for Vidura, a sanitation logistics service provider in Kigali, Rwanda. And here I would like to acknowledge the support of the whole Vidura team that supported this research throughout the study. Firstly, as much as tremendous improvements have been made in regards to figure sludge management services, there are still quite a number of challenges which trickle down to the fact that emptying pit latrines is inefficient. And this is mainly symbolized by the fact that the operating costs exceed the spending capacities of low-income households, where we found from our literature review that the willingness to pay by customers is around 30 to 50% of the market value of respective services. As a result, most exhauster truck companies do not serve pit latrines and have little interest to do so because of limited viability. This means there's a dire need to improve operations to reduce operating costs below customers' ability to pay. And in this, I hope it works. I saw in the Pathable platform, there's a poll section if you are interested. I would like to ask you here what you as experts from the FSM field think is what do you identify as the biggest challenges and entry barriers for viable FSM businesses? There are several answers predefined, but you can also choose others and you can select multiple options if you feel that the biggest challenges are not mentioned here. I hope you are able to find it. It's right in the tab next to the chat section. So call centers are an emerging way, an emerging approach to increase sanitation service delivery, mainly used to aggregate demand in geographic clusters and to support the streamlining of sales processes and optimize operations logistics. During the study period, we studied several key interventions, starting with the launch of a CRM system at the Pit Vidura call center in February 2019, which enabled Pit Vidura to track sales data in a much greater level of detail. And it is shown here that there are several interventions linked to processes, marketing interventions, and human resource interventions. For example, there was a call center intern that was hired in May 2019, purely dedicated to handle the incoming demand. And another staff addition in 1 year later in May 2020, with the hiring of a marketing and sales manager to support the implementation of standard operating procedures. In August 2019, there was a mass marketing campaign that was launched alongside the introduction of a scheduling regime with the aim to streamline these processes. There was a launch of a World Toilet Day promotion campaign that gave discounts to customers in November 2019 for World Toilet Day. And the call center working hours were increased, prolonged in May 2020, which I will talk about very soon because that had a significant impact. That happened in May 2020. So when we looked at the call center metrics, we saw that throughout the study period, the abandoned calls, also known as missed calls, and the callback times were significantly reduced, where we saw in the beginning of the study period abandonment rates of over 90%, which dropped to less than 10% from July 2020. And the callback times in the beginning of the study period were sometimes even over 24 hours to call back potential customers, which were reduced to just a few minutes, around 8 minutes on average. What was very interesting here was that only 71% of all calls were received between or within the normal working hours between 8 a.m. and 5 p.m., but 96% of all calls were received between 6 a.m. and 9 p.m., which then also leads to the conclusion of a necessity of a demand-oriented call center working hours, which should here be defined between 6 a.m. and 9 p.m. One other interesting finding was that the conversion rates for call-ins decreased with increased call volumes. There we found correlation coefficients between minus 0.7 and negative 0.8 for the calls to leads and calls to empty conversion rates correlated with the call volumes. This shows that targeted marketing is much more effective and important than call volumes. Of course, call volumes, call-ins are important, but it's more important here to focus on the conversion of interested customers. When we look at the empties and the clustered empties throughout the study period, we saw an increase from 32 to 53 empties per month throughout the study period. The clusters, the number of clusters increased in total, but in around the same range so that the clustering rate remained near constant. Clusters in our study means that we have several empties in the same geographic area of the city on a single day. And what was a very interesting finding was that the mechanization increased from 38% to 66%, which means that at the end of the study period, two-thirds of the empties were executed using an exhauster truck. The remaining empties were done with a semi-mechanized process where the sludge is first pumped to the top of the pit with a portable vacuum pump and then filled into barrels, and those barrels are manually transported to a flatbed truck, which is a quite cumbersome but oftentimes still necessary process, which takes a lot of time and leads to high operating expenses. But what does this tell us about the profitability of the business? So for that, we also looked into the economic numbers, economic figures, and we saw that the cost per empty reduced by 22% within the study period. You may wonder why there's this gap in the graph on the top left that you see here. This was where we had inconsistent financial data where certain cost positions were not disaggregated. So we left them out to not distort the charts. Another interesting finding that you see in this chart is that the customer acquisition costs, the green bars, are extremely high for August and September 2019, where the same time when the mass marketing campaigns were launched, showing this increase, but that went down to sort of a normal level around 15 to 20% from the beginning of 2020. We found that the empties per month directly correlate with the cost per empty, which was quite interesting to see in the chart in the bottom left, where when we executed more than 20 empties per truck in a single month, the direct emptying costs were less than $60. Whereas when we didn't achieve 20 or more empties per month with a single truck, the direct empty costs were above $60. And here we couldn't see any significant cost reduction through clustering, which leads me to a potential other poll question, where when we look at the literature, most of the literature, research and books talk about transfer stations. But also in my experience and career of roughly 7 years in the field of fecal sludge management, I haven't really come across many transfer stations so far. And I would really like to know from you if you have come across transfer stations, operational transfer stations. And therefore, we have another poll question that's giving the options that yes, there are transfer stations, they are implemented and operational, there are transfer stations in planning. Yes, I've come across them, but no concrete operations or implementations in plan, or no, I haven't come across them. That would really interest me. With that, we come to the conclusions that call centers can certainly improve sanitation service delivery to drive sales and improved enterprise resource management. In our particular example, the team and truck allocation and the degree of mechanization. The empties per month and the level of mechanizations were the most sensitive cost drivers, and transfer stations are needed for effective demand aggregation and logistics optimizations. For organizations who look into the setup of sanitation call centers, there should be a focus on high call center responsiveness, a focus on high conversion rates, and the call center should be implemented and integrated alongside other innovations such as geospatial analysis to support routing and logistics optimization, emptying technologies, and transfer stations. And I am happy to ask for your questions, and thank you for your attention.
Thank you so much, Dennis, for such a great presentation. Again, I'm going to direct everyone to the Pathable Chat tab for any questions that you may have. We have about 4 minutes for questions before this session ends. Yes, so we have a question from Chris that asks, Chris is curious about how you would presume that the cost structure would change in a rural setting. Is there a density of customers or household institution that's needed to get the target emptying volume needed to cost in or around that $60 figure?
Okay, I mean, this study, yes, that's a great question. And of course, the urban-rural setting is a very important factor on the cost of emptying. But since we are in Kigali. The ones of you who know the setup, we actually do have quite rural areas in Kigali. However, that's certainly different from a purely rural setup. We've done a number of literature reviews, and I remember a study from Bangladesh looking into rural areas where the numbers were actually lower than in our context. However, we have to say here that every study that we obtained found that generally the MTM costs are much lower in Asian settings than in African settings. I hope that's at least partially answering the question, because we only purely looked in the context of Kigali, Rwanda here, and didn't really do much of a comparison and comparative study on the urban or rural context.
Thank you. So we have another question from Anissa, who's asking, once a call is received, how are they allotted to the FSM teams, for example, a prefix or roster? Oftentimes, private operators have defined service areas and independent pricing mechanism. Did you face any barriers in getting the FSM operators to participate in the system?
Okay, here I think I have to clarify the setup. Pitvidura operates differently from other call centers that I'm aware of in, for example, Dakar in Senegal or in Kampala, where the call centers are managed by the utilities or public sector entities. Here, Pitvidura, as a private service provider, operates their own call center and doesn't transfer the jobs to other companies. What happens here is that a call-in comes in and the call center agent is doing a pre-assessment of the sanitation system. And with that, a PIT evaluator is sent to the site when a down payment the PIT evaluation comes first, where we then say this can be served by an exhauster truck or by the semi-mechanized flatbed truck system. So the setup of the call center is already a bit different, but we have different sales stages and use now pre-latrine assessment through the call center to already root out certain non-emptiable latrines. For example, when they are far from full, we tell customers that it's not feasible or viable to empty them.
Thank you. As we are short on time, we are going to take one last question from Jonathan, who's asking, what is the size of your trucks and the average volume being removed per trip? Also, did the household trust the operator when they came with a partially filled truck?
Yes, that's a particular challenge. So when we empty pit latrines, that's usually 2 cubic meters emptied, and the flatbed truck can fit exactly 5 cubic meters, which is then in a practical sense 2 pit latrines per 1 truck filling. The exhauster truck, there's 2 exhauster trucks. One, the smaller one, has a volume of 10 cubic meters, which is also used to empty pit latrines. And the second one has 20 cubic meters, which purely empties institutions and larger size septic tanks. But the skepticism is there, yes, but not so much with the barrel system, because there the clients can count that it's a set number of 60-liter barrels.
Great. So we just arrived the last seconds of our Q&A for Dennis. Again, if you have any more questions, you are able to reach out to the speakers through the conference website, and you can send a quick message, a quick hello about any more questions you may have. So that's it. There's no more presenters for today. Thank you so much, Dennis, Christine, and Erica, for your presentations. I'm pretty sure I've learned a lot, and everyone else too definitely had. Any more? So we have our closing announcements, which is almost reiterating what we spoke about earlier. So there are other rooms that you are able to go to and attend more sessions. And there's, again, the early morning show or an evening show that you may want to watch, because there's always something great happening. And we have the Water Institute working really hard, offering a lot of platforms and a lot of sessions to go to. So that was it. Thank you so much for your time and thank you for coming to this session.